and welcome to SureenaSpeaks, and in this video I'm going to be comparing asthma to COPD. This video was requested by one of you lovely lot, and as always, if you want me to make a video on a particular topic, please feel free to get in touch via Instagram, Twitter, Facebook, or drop a message in the comment box below and I'll see what I can do for you. So with this video, not only am I going to compare asthma to COPD, I'm also going to refocus on the management and treatment used in COPD. I've made several videos on asthma guidelines comparing NICE to BTS, so I'll include that link in the description box below, but I'm really going to focus more on COPD management in this particular video. So what is COPD? COPD is chronic obstructive pulmonary disease, and both asthma and COPD are respiratory diseases, and it can be quite difficult to differentiate between one from the other. So ways in which we can do that are by identifying airflow limitation, looking at symptoms, so is there any mucus being produced, for example? Is there any inflammation? Are there symptoms of coughing and wheezing? Now, something like COPD, it is preventable and it's characterised by airflow limitation that is usually progressive and it's not fully reversible. It is characterised by inflammation of the small airways, so bronchiolitis, and destruction of lung parenchyma. I never know how to say that word, so I hope I'm saying it correctly. So let's compare asthma to COPD. So asthma is usually seen in childhood, not always, but it tends to begin in childhood. Whereas COPD usually presents in those over 40. It's very rare to see someone under 40 with COPD. Now asthma, it can occur in smokers and non-smokers, whereas with COPD, it's typically seen in smokers or ex-smokers. Now I remember years ago I did a smoking cessation course and it was really useful. And when you have a patient in front of you and you're trying to figure out whether they're a smoker or they're not a smoker or they're an ex-smoker, they actually taught us to ask a really simple question in trying to identify whether a patient is a smoker or not. Now you might think that question is simply, do you smoke? But actually by asking such a closed question, sometimes people can feel like you're almost attacking them or prejudging them. I guess it's just one of those things. So they actually taught us that it's better to ask an open-ended question instead. And actually by asking, does anyone in your household smoke? That then presents them with an opportunity to say, oh yes, actually I smoke, or my partner smokes, or whoever else may be in their household that's potentially a smoker. So by asking an open-ended question rather than a closed question, you're actually more likely to get more information out of a person. And then it can start that conversation of, okay, so have you ever considered stopping smoking? So actually seeing if a smoking cessation service would be something that they would be open to. Sorry, that was just a little side note. Back to asthma and COPD. Also worth noting, so if you see in questions, for example, or past papers, and they mention, say the question wants you to identify whether this patient has asthma or they have COPD, finding out or trying to read in the question or in the case study if they are a smoker or an ex-smoker is usually quite a good giveaway. But like I said, bear in mind that if you are a smoker, that doesn't necessarily mean that you will always have COPD, because it can occur in asthmatics as well. Now with asthma, it's usually triggered by, something such as an allergy. So pollen, dust, animal fur, for example. Some people get exercise-induced asthma. So I guess in a way you could say that some people are allergic to exercise. And it is more common in a family history of asthma. And usually eczema, hay fever and asthma, they're always almost interlinked. So if someone suffers from hay fever or they suffer from eczema, it's likely that they have asthma as well. The key symptoms of an asthma include wheezing, breathlessness, a tight chest and coughing. But many reasons can cause these symptoms, so it's really important that we're able to identify that this is actually asthma and it isn't something else. So the key things with asthma is that it can happen often, it keeps coming back, and it is worse at night time. So having those nighttime symptoms is a key giveaway usually that this person has asthma. Symptoms of COPD, however, they include dyspnea, wheeze, a chronic cough, and usually sputum production, so mucus production. that's kind of a bit of a giveaway that it's likely to be COPD rather than it is asthma. So that was a brief overview on the differences between asthma and COPD. Now let's think of treatment. So as I mentioned, please do refer back to my videos in the description box below for more on asthma. And now I'm going to really focus on COPD. So like with anything, non-pharmacological advice should always be given. And as I was saying previously, a key one for smokers, particularly if they have asthma or COPD, is smoking cessation. So counselling should always be given to on diet, so good nutrition, weight loss or weight gain, depending on the circumstances, and exercise as well. And bear in mind, if someone does have exercise-induced asthma, you do give them the appropriate counselling and advice on that. So in order to understand why a particular treatment is given, it's worth us taking a step back and looking at the nitty-gritty key differences between the nature of inflammation in asthma and COPD. So in asthma, inflammation is mainly caused by, again, this is another word which I always have difficulty in saying, caused by eosinophils? Why they can't make words easier, I do not know and I will never understand, but let's go along with eosinophils, and I'm probably most sure that I'm not pronouncing that correctly. But what this is, it's a type of a white blood cell basically. Whereas in COPD, it's the neutrophils that are involved. Again, this is another type of white blood cell, but it's two different ones. So eosinophils with asthma, and with COPD, we have neutrophils. A good way of remembering it is asthma and eosinophils, both the words start with vowels, A and E, whereas with COPD and neutrophils, they both start with consonants. So again, just a little quirky way of trying to remember it. So why is this important to know? It's important to know because the nature of the inflammation affects what treatment is given. So corticosteroids, they're effective against eosinophilic inflammation, but they are largely ineffective against neutrophilic inflammation. So this explains why usually first-line maintenance therapy in asthma is an inhaled corticosteroid, whereas in COPD, bronchodilators are usually first-line. So during exacerbations of COPD and asthma, the patterns of inflammation become quite similar. So in exacerbations of asthma triggered by viruses, there can be an increase in the number of neutrophils, in addition to the rise of the eosinophils. And in COPD exacerbations, there may be an increase in the number of eosinophil. This is why corticosteroids are prescribed in COPD patients to manage exacerbations. So whilst the eosinophils are mostly associated with asthma and the neutrophils associated with COPD, it's during these periods of exacerbation that those patterns of inflammation become very similar. So there is a really good visual summary treatment algorithm in NICE guidelines, and I'll include that link in the description box below. And that's what I'm going to talk us through now when we're looking at the management and the treatment of COPD. So let's assume we have a patient, they have been confirmed and diagnosed with COPD. The first thing that we're going to do after offering, of course, giving our non-pharmacological advice, offering smoking cessation if they're a smoker, etc. We're going to offer either a short-acting beta-2 agonist, so a SABA, or a short-acting muscarinic antagonist, a SAMA, to use when needed. Now, say if a person is limited by their symptoms or they're still having exacerbations despite their treatment, we then need to step up their therapy. And we will step up their therapy depending on whether or not they have any asthmatic features. So let's assume this person has no asthmatic features or features suggesting steroid responsiveness. In that situation, we are going to offer a long-acting beta-2 agonist and a long-acting muscarinic antagonist. We're going to offer the both of them. Now, bear in mind, if beforehand the person was on a short-acting muscarinic antagonist, that will need to be discontinued if you're then going to add on the long-acting muscarinic antagonist, because a person should not be on a SAMA and a LAMA together. SAMA and LAMA, nice little rhyme, but they shouldn't be on the two together. So we'll have either the SABA or the SAMA. Remember, if they're on the SAMA, we will discontinue that, and we're going to offer a LABA and a LAMA. Now, if the person has day-to-day symptoms that still are really affecting their quality of life, we will then need to add on an inhaled corticosteroid. So they're on triple therapy. They're on a LABA, they're on a LAMA, and they're on inhaled corticosteroid. And that would be trialed for about 3 months. If after 3 months there's still really no improvement, there's no benefit, then the inhaled corticosteroid should be stopped and the LABA and the LAMA should still be continued. Now, if you have a patient, for example, who day-to-day symptoms are actually not that bad, but within a year they've had 1 severe or 2 moderate exacerbations, then again we would want to consider that triple therapy of a LABA, LAMA and an inhaled corticosteroid. Now that was a pathway if a person didn't have any asthmatic features. Now if we have a person who does have asthmatic features, as we had learnt beforehand, if they have asthmatic features and it's likely that their eosinophilic inflammation is quite high, then we know that inhaled corticosteroid will be really beneficial in this situation. So that's why if a patient has any asthmatic features or features suggesting steroid responsiveness, then we want to actually consider a LABA and an inhaled corticosteroid. So whereas in the other situation we had a LABA and a LAMA, in this one we're going to have a LABA and an inhaled corticosteroid. And again, if the person has day-to-day, they have symptoms which are really affecting their quality of life, or they have a really severe or 2 moderate exacerbations within a year, then we're going to offer triple therapy. So in both situations, the very first thing that they would start with, a SABA or a SAMA, is the same. If things get really, really bad, we're going to give triple therapy, but it's that difference that comes in the middle, and that difference is decided on whether or not they have those asthmatic features or they don't have those asthmatic features. I really recommend that you print off the that visual summary treatment guide and stick it somewhere which you're going to see every day, because it is such a really nicely detailed bit of information. It's a really nice poster that you can use as well, so really recommend that you do have a look at that. Again, as pharmacists, it's our role to make sure that we're educating our patients, that we're counselling them appropriately, and that we're ensuring that the inhalers that they're using, they do know how to use them, and the importance of ensuring that they do take their treatment when they need to take it and that they're not missing doses. So with COPD, there are other additional medicines that are prescribed. It's not just, the long-acting beta-2 agonists or the long-acting muscarinic antagonists or the inhaled corticosteroids. There's other medication as well. So one of them, for example, is roflumilast. Again, this is one that is a fun word to say. And this is an add-on treatment to bronchodilator therapy in patients with severe COPD with chronic bronchitis. And it's usually only prescribed under specialist initiation. You might also need a mucolytic. So we mentioned that with COPD, a patient could have a lot of mucus or sputum buildup. So a mucolytic, such as carbamazepine, that can be prescribed in patients with a chronic cough, with productive of sputum, and it should only really be continued if symptomatic improvement is seen. But it can be really helpful for all that mucus buildup that the patient might be experiencing. Modified release theophylline is another one. This should only be used after a trial of a short-acting beta-2 agonist or a long-acting beta-2 agonist, or if the patient is unable to use an inhaled treatment. There's also aminophylline. This should only be used as add-on treatment when there is an inadequate response to nebulized bronchodilators, and ensure that therapeutic drug monitoring is required and previous oral theophylline use should be considered first to avoid any toxicity. Prednisolone as well, so you may have seen prescriptions, for example, for a short course of prednisolone for someone with COPD. This may be used to manage their exacerbations. And if necessary, oxygen. That may be required to ensure that the oxygen saturation of arterial blood levels are kept within their target range for the patient. So there's a lot of different medicines and a lot of different treatments that go into a patient with COPD. So what are the take-home messages? So the take-home messages are the differences between asthma and COPD, identifying the treatment pathways within COPD as well, whilst also acknowledging that there are additional medications that potentially need to be used. Ensuring that with medications such as theophylline, you do know what the therapeutic range is for theophylline. And a really key take-home message is ensuring that you know how to counsel your patients on the different types of inhalers as well. So don't ever be afraid to, especially if you're in a community setting, don't ever be afraid to open up the patient information leaflet in front of the patient and go through the directions step by step with them. Ensuring that your patient knows how to use their inhaler appropriately will then ensure that they are getting the most out of their treatment. Take your time with your patients to make sure that they fully do understand the importance of taking their medication and using their inhalers accordingly and appropriately. So I hope you found this video useful, and if you did, why not give it a thumbs up? Share, like, subscribe. As mentioned before, please always feel free to get in touch via Facebook, Instagram, or Twitter, or writing comments below underneath the videos. Your support is always really appreciated. So thank you so much for watching, and happy revising.